Jeremy, walk us through what direct primary care is.
Yeah, John, I'll be happy to. And thank you for everybody who's attending. I appreciate your time. Um, so, at the core, and the reason they invited me to this is something called direct primary care. And it is the opposite of the way we've done medicine for years, the early part of my career up until the last 7 years, which was in order to get paid as a doctor, you had to do something to somebody. You had to see them, you had to physically touch them and intervene, and then you had to send a bill to somebody other than the patient to get paid for that. And that whole process is broken. It puts incentives in the wrong place. It is resulting in healthcare costs going completely nuts and out of control. And so direct primary care is the opposite of that. The only person that you work for is the person directly in front of you. And so that's the concept of direct primary care. It's done on a monthly retainer basis, much like going to the gym, where you've paid your fee, you're there, you're in a membership based practice, and it's the incentives are aligned. It's you and the doc. And then we've taken that and we've done it with technology in today's world where it's literally on your phone. So either in person or mostly on the phone, you've got a consultant, which happens to be your physician at the same time. So that's the concept of direct primary care. So next question, obviously, is how does that work? It works really well. Now, when you take it into the employer world, and that's kind of the subject for you guys, is you want to harness that direct primary care doctor as the hub of where employees go to get medical services. Without that, without a direct primary care doc, they're kind of left to the wind of the marketplace. And as you all know, the marketplace for medicine is awful. It's got pitfalls everywhere, not only for the patient, but for the health plan that they're associated with. These poor employers are basically given a credit card with very, very few limits called their health plan to patients to go out and be preyed upon by hospital systems, doctors and hospital systems that don't really even understand how the thing works. So direct primary care becomes an educated doctor that understands the way the health plan works, understands the needs of the patients, puts all of those options together to try to find what's the best route for you, what's the best route for the patient. And in turn, employees and employers save a ton of money. And that is not limited to just what a PCP can do. No, that's directing to get imaging, directing to get specialist care, making sure the drugs are done correctly. I mean, we all know that's where everyone hides the money. I mean, the drug costs are completely out of sorts. So we've got the direct primary care harnessed at the hub of all of these things and becomes the guide or the financial consultant in addition to the doctor.
Awesome.
So some of the perks that we'll point out is this is truly 24/7 access to your doctor. It's not a random physician. So you've got a relationship. You don't just start with a need. You start with building a relationship with that doctor. And I tell people it's like having a brother-in-law that's a doctor. You wouldn't hesitate to just text him, hey, this is what's going on. Susie stepped on a nail. What do I need to know about this? Rather than going to Google and trying to figure that out because, 3 clicks on Google, you're dead, and certainly headed to the ER to find out if how quickly you're going to die. So same doc, 24/7, couldn't be easier access on the phone, and all the types of doctors that we work with have bucked the system that is awful, that doesn't have customer service. So it's kind of a good filter when you're looking for a doc to say, gosh, at least they're a direct primary care doc. They get it. They understand. So MyMD Connect, we even furthermore filter those docs out and try to get the best of the best to take care of our employers and their patients.
Awesome. Thank you, Jeremy, for that overview of what direct primary care is and kind of how that works with MyMD Connect.
Welcome.
So really, it's amazing everything that you guys do within MyMD Connect that we just overviewed. But a question that I do get a lot is what happens, when an emergency arises. Direct primary care is really there for, when you know that you're going to need a doctor and it's not an emergency. And so it's great when that, you have something that's planned. But what happens when it's an emergency and, it's not a planned appointment? Can you walk us through how you handle that?
Sure. And as you can imagine, there's 500 things that could happen that are awful in an emergent situation. If you'll advance to the ER slide we put together, the best thing that can happen is we do want that patient to reach out to their doctor and say, before I take my first step, which is likely in the wrong direction, let me run down the quick version of what's going on with me. And so the MyMD Connect doc's going to receive that and evaluate and triage it very quickly. And if it's an ER worthy thing, we're going to get that patient to the ER. But there's at least a layer of where does a patient need to go? What is built into their plan? Do they have a narrow network? Where's the best quality place for the dollar for that patient to go? Which ER, in other words, we're going to get them there. Most of the time, I'll tell you, patients have been on Google, unfortunately. They're dying, so they're headed to the ER, and often they don't need to go there. So we kind of cool the jets, talk them off the ledge, if you will. I've talked to patients out of the ER waiting room while they're sitting there waiting to be seen. They're like, hey, I forgot I had my doctor. And so we evaluate them. They may need a lot more than we can do right now on the phone. They may need labs, specialists, urgent care. MyMD Connect is the hub. We'll get that all set up in a urgent manner outside of the ER. And then finally, those results will come back to us, the doctor, so that we can do that continuity of care and get the whole loop taken care of. So that's, as you can see, this is a simplification of a very complex problem. And it's just simply, hey, I don't know what to do. And almost every time the patient takes the wrong step. So let the doctor guide the patient. There's all kinds of advocacy programs out there, and I love them, but it's best if it's the doctor starting that process.
Jeremy, one last question, and folks, you'll be able to ask Jeremy other questions here at the end. A common misconception is that because this can be offered virtually, that it is telemedicine. Explain how that is not the case.
So telemedicine is a cheap bank of physicians. So telemedicine is a very cheap product. You can add it onto your health plan, but what it is, it acts a lot like Uber. If you've used the Uber driving app, if you need a medical care or a ride in this analogy, you just say, hey, I've got this going on. I need to go to this place. And random physician or random driver shows up to take care of your job. They don't know who you are. There's got to be some form of download of what's your situation. Who are you? It's redundant. And you got to do this over and over. And God forbid, tomorrow you're not getting better. You call back. It's going to be yet another physician. So telemedicine really is a bank of doctors, random physicians, and they're pretty good at just doing acute care with the blinders on that thing. The direct primary care doctor has all the same types of tools as far as access and web capabilities and programming. So people think the telemedicine platform is the same. It's the product that's different. It's your physician every time. So you don't have to go through all the same rigmarole, and you've got the continuity of care. Yeah, I already know I know the patient. As soon as they call me, we don't have to go into that. Mm-hmm. So that's the difference between telemedicine and direct primary care in the virtual space. So that virtual primary care piece.
Yeah. Great. Awesome. I know one thing that was really impactful for me the first time I utilized it was the amount of time my doctor spent with me, 45 minutes as opposed to the normal 6-minute visit. It's just a completely different experience. I have one question here. It says, Jeremy, so this one's for Dr. Smith. It says, Jeremy, you talked about how you handle emergency care, but what about something more serious that you know ahead of time about, like maternity or cancer? Does MyMD Connect help with that?
Yes, and we'll take maternity. So the first thing is, what does the plan, what's behind the direct primary care doctor that the patient has access to? For example, we've got a fully insured plan in Texas right now where we've got 3 people that are pregnant. So we're actively managing what's that going to look like when they get to the hospital. And in that case, this is a plan that's actually gone in and they don't have a network. They've given MyMD the authority to source even the maternity care, hospital bills, anything within that normal delivery. So what that looks like for those patients is MyMD is actually advocating sending them through that hospital capturing and paying as if they were a cash patient. The patient's not paying, MyMD Connect is paying. We're getting reimbursed back from the plan. So the patient experience is she's going to show up and have her baby. That's it. If something were to go wrong, we've also secured a single case agreement on a discount basis. Think of it as an extreme narrow network for her, because not everything goes as planned. Or the other end of the spectrum, they have a plan. They don't have any plan. They've got direct primary care and that's it. So we are going to help manage and facilitate. They don't know. And my last child, we had a C-section. It was $4,500 all in. The patients don't know that. They show up, and if that's not prearranged, I mean, they could get hit $37,000, $40,000 bill, and they put it on a payment plan from now until their great grandkids get it paid off. So it doesn't matter what this scenario is: cancer, maternity. The doc, MyMD, is going to say, what are the tools? What are the plan? What is available through the employer health plan? And if not, how can we get this done? There is a best value scenario for every scenario. We're going to chase that one down.
The next question that we have says, regarding brick and mortar, what is the network? Can employees keep their doctors? So that's a great question. The thing though is, in regards to keeping the doctor, we are the ones that go out and we recruit our doctors, because what we're doing is completely different than your normal fee for service doctor, where you're just going in and the doctor's being wants to see as many patients as possible because they're getting paid for each patient they see, as opposed to a membership model where it's concierge medicine. You're spending 45 minutes with your doctor. Completely different models there. So in regards to wanting to keep your specific doctor, it is a different model. It would have to be a doctor that is a concierge doctor. Certainly if you have someone. Jeremy, did you want to chime in on that?
I did, because I read that question a bit differently. So
okay.
Kaylin said exactly right. The direct primary care and virtual primary care, this is a different breed of doctor. Mm-hmm. But if the patient has a primary care doctor with a network, and you can put any network on these plans you want. We can work with any network. It doesn't matter. But more importantly, they can keep their primary care doctor that they have a relationship with. The direct primary care doctor, I do this all the time. Like, if you like your doctor, and most people don't have this relationship, but when they do, that doctor's still not open Thursday at 7 p.m. and they're not able to see you tomorrow. That's just not the case in this world. So yes, they can keep that physician, and the DPC fills in the gaps. And I tell you, we end up doing more work for the patient and their primary care as that kind of backup assistant, after hours, weekends, things like that. But in most cases, patients don't have that relationship. I mean, if they did, then maybe this industry wouldn't be in such a mess. But when it's there, we won't disrupt that. We don't want to disrupt that.
Great. Hopefully, I'm glad that you read that differently. So hopefully that answered your question. The next question is, what is physician reimbursement under the discounted fee structure, perhaps best described as a percentage of Medicare? Jeremy, did you want to answer that question?
Yes. Again, you can design any type of plan you want. What we frequently do is use a Medicare reimbursement plan for our major medical coverage plans, and they run physician 130, facility runs between 150 all the way up to 200% of Medicare, depending on where we're at. And we do have the ability to put those types of direct agreements together. We've got many of them already established, but you can build the plan any way you want, and we can assist you. There was one earlier slide where when it said discounted on the actual DPC membership. So most carriers are going to afford you 60 something percent off. I mean, it's going to vary 5 or 6%. But when we do labs internally with direct primary care and they're not capitated, it's just the patient having to come to us to acquire something, we're at about 90% off bill charges, almost across the board.
Are functional medicine doctors available?
You're looking at one. Yeah, so I am a functional medicine doctor. You talk about a rare breed within a rare breed. Yes, sir. And we have a handful, but even amongst direct primary care, that's a very small segment of physician. But we do have several, and I'm kind of the central point for tough patients. I enjoy that. So great question. I love functional medicine. I am IFM trained, and we do have some access to that. I would love, and in the future, be able to build a plan that's just focused on functional medicine. But whew, it's to harness that to a structured health plan. I don't think that's ever been done, like in the history of the world. So I would love to be a part of that. If you've got ideas, let's get together on that. I would love to see that happen.